Good day, everyone. Welcome to this session. In our previous session, we learned that silent hypoxia means the patient has low oxygen levels but does not look very sick. In telehealth, this is dangerous because the patient may appear calm on video, yet be seriously unwell. We also discussed about respiratory risk in telehealth. We learned that clinicians should think about what serious condition could be, not just the symptoms. By the end of this module, participants will be able to 1. Use a structured telehealth respiratory assessment script to gather and record required information. 2. Know when is telehealth unsafe for respiratory presentations. 3. Understand how respiratory escalation should be communicated clearly and safely. Now, let's discuss what should be included in a structured telehealth respiratory assessment. A safe telehealth respiratory assessment should be structured and consistent. It should include 1. Core symptom clarification. It comes with questions like: when did the breathlessness start? Did it begin suddenly or gradually? What makes it worse? Is it happening at rest or only on activity? What can the patient no longer do? Next is trajectory. They ask questions like: is it improving, the same, or worsening? Is it worse today than yesterday? And is the change rapid or gradual? Next is remote safety checks. They ask things like: can the patient speak in full sentences? Is breathing effort visible? Can they walk a few steps safely? Is there confusion, chest pain, fainting, blue lips, or inability to stay awake? Are there any home readings such as pulse oximeter, respiratory rate, or pulse? And finally is context and vulnerability. It include age, pregnancy or postpartum status, chronic disease, home support, transport access, distance from emergency care, and ability to follow instructions. Note: this structure helps reduce misdeterioration. Next, we will discuss when telehealth is unsafe for respiratory presentations. Telehealth becomes unsafe when respiratory risk is increasing and cannot be confidently managed at a distance. Emergency escalation is needed when there is breathlessness at rest with inability to speak normally, rapid worsening over hours, marked change from baseline, new confusion or severe drowsiness, collapse or syncope, severe chest pain or pleuritic pain, blue lips or severe visible distress, a high-risk patient with unclear severity and limited support. Next is same-day in-person assessment is needed when there is moderate breathlessness with uncertain cause, new wheeze or suspected infection in a vulnerable patient, reduced activity tolerance with concerning progression, and lastly is no home monitoring, and risk cannot be safely bounded. Note: in telehealth, escalation is based on risk, trajectory, and vulnerability, not on waiting for full certainty. Lastly, we will focus on how should respiratory escalation be communicated clearly and safely. Respiratory escalation must be communicated clearly because patients may minimize symptoms, delay action, or misunderstand urgency. Good escalation communication should include 1. State the concern clearly. That is to explain what risk you are worried about. 2. Is to Explain why telehealth is not enough right now. This is to tell the patient why remote care is no longer safe. 3. Give a clear action. For example, call emergency services now. Go to the emergency unit now. Attend urgent same-day review. Next is to check understanding and ability to act. Ask about transport money, companion support, distance, caregiver help, and lastly, document clearly. Record the reason for escalation and the advice given. Note: risk communication must be plain, direct, and practical. In conclusion, we have learned that a structured telehealth respiratory assessment should be systematic and thorough. The clinician must understand the patient's symptoms, assess symptom progression over time. We have come to the end of this session. Thank you for watching. See you in the next session.